Welcome to another episode with Coffee with Doc. I am your host and solo podcaster today, Dr. John Pierce. This is episode number 45. So, for those of you who've been with us, thank you. And if this is your first time, please enjoy. So, in this episode, I want to talk about estradiol. But what I want to talk about estradiol is its effects on the brain. So, why menopause is a brain event, estradiol, brain metabolism, and the symptoms women feel. We're going to talk about something many women experience, but very few have ever properly explained. Menopause is usually framed as a reproductive event. Periods stop, hormones change, hot flashes, night sweats start to happen. But what if menopause is also a neurological event and a metabolic event? And that's what I really want to delve into today. What if the symptoms many women describe, brain fog, memory lapse, sleep disruption, anxiety, low mood, and even hot flashes, are rooted in the changes in how the brain fuels itself? Today, we're going to explore the medical literature that shows about estradiol and brain metabolism and how their relationship helps explain the symptoms of menopause without speculation, hype, or pseudoscience. Let's start with a foundational concept. Estradiol, specifically 17-beta estradiol, the main estradiol produced by the ovaries, so 80% of ovarian estrogen in normal, healthy ovarian function is in the form of 17-beta estradiol. It's not just a reproductive hormone, but it's also a brain active hormone. And we've talked about this in other podcasts, but it is neuroactive. It's a neural hormone. So estrogen receptors are found throughout the brain. In the hippocampus, for memory, the frontal cortex, which is important for your attention and executive function, the hypothalamus, so that's where hormones are released, but it also has temperature regulation, hunger, thirst regulation, and your sleep, and also in your amygdala. And that is responsible for emotional regulation and mood. From a metabolic standpoint, estradiol plays a key role in how the brain transports glucose into the neurons, runs aerobic glycolysis, so that is with the utilization of oxygen, maintains mitochondrial function, and produces ATP, the energy currency of cellular metabolism. In simple terms, estradiol helps the brain access fuel efficiently and burn it cleanly. This isn't theoretical. Multiple reviews describe estrogen as a master regulator of cerebral bioenergetics, particularly glucose metabolism and mitochondrial energy production. What happens during the menopause transition? So let's talk about what changes during menopause. During the menopause transition, especially perimenopause, levels of estradiol decline rapidly and unpredictably. So in my years of practice, I've seen where a woman will come in perimenopause, and depending on when we check their levels, one day they could have an estradiol level as high as 400, which is very, very high. The average production is about 100 to 150 on average over the month. So, and it usually runs a little bit higher. But for instance, ovulation usually takes a level of around 200. And this is picograms per milliliter. So 400 is twice that of what it creates for ovulation, but I've seen levels that high. And the next day, if we were to test on the next day, it could be 0. And this kind of helps to explain why women in perimenopause are all over the place with hot flashes and night sweats and, mood changes and alterations in their menstrual cycles with between heavy flow and light flow and some missing periods. So many, many different symptoms. Eventually, when that transitions into menopause, when the ovaries have retired and they're no longer releasing eggs, or they're also no longer producing hormones such as estradiol, progesterone, and testosterone. They can still make some testosterone from the adrenal glands, but um, you know, we'll just call it very, very low amounts. So that's kind of what's transpiring during that time. Importantly, estradiol levels fall not just in the bloodstream, but they fall within the brain itself. The brain does not make its own estradiol. It's relying on our sexual organs or organs, ovaries, to produce that estradiol. Men make estradiol as well, but this is primarily focused on women in menopause. Men's estradiol is made primarily from the aromatization or transition of or metabolism of testosterone into estradiol. That's exactly how it is made in the ovaries for women. It comes from testosterone in the ovary and is turned into estradiol as well. But, I kind of digress there. Advanced neuroimaging studies show that menopause is associated with measurable changes in cerebral glucose metabolism, brain connectivity, and energy utilization, independent of chronological aging. So primary ovarian failure can cause some brain issues in a very young person. So when I say very young, I mean in their 30s. They can go into premature menopause by primary ovarian failure. In one large multimodal imaging study, researchers compared premenopause, perimenopause, and postmenopausal women. They found lower cerebral glucose metabolism in postmenopausal women, emerging hypometabolism already present during perimenopause, particularly in regions responsible for higher order cognition. So, estradiol is important. So most women start perimenopause someplace between 42 and 52. Menopause on average is at age 52, but that can happen before or after. So just, if you start to feel some changes in, your mood or alterations in your period, this is you going into perimenopause, and that's now the best time to speak with somebody who is well-versed in hormone replacement for women. So this is why the term menopause as a neurologic transition exists in the scientific literature. Not because menopause causes brain damage, but because estradiol withdrawal causes or creates a temporary metabolic stress state in the brain. We know that women are a higher likelihood than men to develop Alzheimer's disease. Is it because this stress state in the brain increases protective proteins secreted by the neurons, which are made of amyloid? Those protective proteins that are made of amyloid accumulate and become the amyloid plaques that we associate with Alzheimer's disease, right? So those are the neurofibrillary tangles that people have talked about. So that may be a piece of why women experience Alzheimer's disease at a greater percentage than men. Another piece of that is because women tend to live about 5 to 7 years longer than men. So maybe they're experiencing because they're aging a little bit longer on average. So it's multifactorial, but this is a consideration. How brain metabolism connects to menopause symptoms. How does this translate into what women actually feel? Let's connect the dots. If the brain is less efficient at transporting glucose has less support for mitochondrial energy production, and is operating in a relatively hypometabolic state, then symptoms make sense. Cognitive symptoms such as brain fog, word finding difficulty, forgetfulness, reduced mental stamina, uh, mood symptoms, anxiety, irritability, low mood, depression, emotional volatility, sleep and temperature dysregulation, night sweats, insomnia, hot flashes. These are not imagined, and they're not just stress. These are real. They reflect estrogen-dependent neural systems under metabolic strain. One particularly interesting finding from a recent PET imaging study is this. As estradiol levels fall, the brain appears to increase estrogen receptor density, essentially trying to capture as much estradiol as possible. Your brain sends out more luteinizing hormone to the ovaries to produce more estrogen. So this is a laboratory finding that we can see. To me, it's a signal screaming to the ovaries, give me more estrogen. But it's also the brain's upregulating estradiol receptors to get as much of that estrogen as it can to itself. This receptor upregulation correctly distinguishes pre versus postmenopausal women. It correlates with memory performance and predicts self-reported cognitive and mood symptoms. In other words, the women with the greatest receptor changes often report the greatest symptoms. This supports a compensatory model, not a degenerative one. Does estradiol replacement affect brain metabolism? This is important. Naturally, that's the next question. Can we give estradiol, and does that affect this process? Human PET studies have looked directly at this. Key findings. Women who continue estradiol-based hormone therapy show relative preservation of cerebral glucose metabolism, particularly in regions vulnerable to cognitive decline. Women who discontinue estradiol show metabolic decline in areas like the posterior cingulate cortex and early Alzheimer's sensitive region. Estradiol-based formulations tend to preserve metabolism more consistently than some non-estradiol formulations, i.e. conjugated equine estrogens, i.e. pregnant mare urine, i.e. Premarin. This is why, in my opinion, bioidentical hormone replacement with estradiol is essential for your brain health and overall long-term health. Adding certain progestins may blunt some of this effect depending on timing and formulation. We're going to talk about the difference between progesterone and progestins next, so just bear that in mind. However, this matters. Large reviews show that timing is critical. Initiating estrogen therapy closer to menopause onset, perimenopause, produces very different brain effects than starting years later. This was one of the flaws in the Women's Health Initiative, is the average age of the nurses study. The average age of those patients was about 62 or 63 years. So on average, they were 10 or 11 years postmenopausal. So for a lot of them, they did not get the benefits of the hormone replacement. That's number one, is because of the age. Number two was the primary form of estrogen used at that time was not estradiol. It was the conjugated equine estrogens. And we've talked about this in the past. This supports the so-called critical window hypothesis. So we want to get it either immediately in as we start perimenopause, or That would be optimal, or very minimal as we go into menopause immediately. It can be started within 10 years safely afterwards, but the effects aren't going to be as profound as when we get it on board earlier. This is something relatively new for me over the last few years because I was taught earlier on if a woman was in perimenopause not to give them estradiol at the time because we had seen fluctuations going up to, up to 400 or so. You're like, well, they're not estradiol deficient if they got a level of 400. What what I learned was or what I lacked of understanding at that time was the vast fluctuations in that estradiol. One day it could be 400, the next day it could be 0. So what we're trying to do when we give estradiol in that window is kind of give a steady state, an even keel estradiol level. And sometimes in perimenopause we give much less than what we do in menopause, and then titrate up as the woman progresses. Estradiol, therefore, is the most effective when the neurons are still metabolically healthy enough to respond. Right, so that's the whole key, is just catch them early in the process. Let's bring this back to real world medicine. This is important. The evidence does not say these things. It does not say every woman must take hormone therapy, or that estradiol prevents dementia, or that menopause permanently damages the brain. Now, we know that we can protect the brain, but we don't want to go out and say, well, if you take estradiol, you can't get dementia. You're going to reduce the likelihood of it, but it does not prevent it. What it does say is this: menopause is a brain-relevant metabolic transition. Estradiol supports brain energy metabolism. Its loss can explain many menopausal symptoms. Cognitive and mood changes during menopause are biologically grounded, not psychological weakness. Personalization matters. Timing, formulations, and risk profile. This reframes menopause not as hormones declining, but as a shift in how the brain manages energy. Menopause isn't just about the ovaries. It's about the brain's fuel supply, its adaptability, and its resilience. Understanding estradiol as a brain metabolic hormone helps remove shame from symptoms, clarity from confusion, and pseudoscience from the conversation. Most importantly, it gives women language, science, and validation for what they are experiencing. If you found this helpful, share it with someone who's been told their symptoms are just part of aging, because science tells us there's so much more to the story. If you have more questions or want to embark in a bioidentical hormone replacement therapy, please contact us here at Ageless Forever, 702-838-1994, www.agelessforever.net. If you are not local to the Las Vegas area and you want some areas that you can find providers who have been well trained in bioidentical hormone replacement therapy, I suggest one of 3 platforms. There are many more, but WorldLink Medical will have providers that have the certified providers that have undergone extensive training in women's hormone replacement therapy. You can look at the American Academy of Anti-Aging Medicine. There are many very good providers there. There's Age Management and Medical Group. Those are 3 organizations that I either currently or have formerly belonged to. And there are plenty others out there, but try to find somebody who's been doing this for a few years, and you are not going to be their crash test dummy, because with women's hormones, it is balanced. Men, we're simple. Testosterone, that's one ball to juggle. With women, it is testosterone, estradiol, and progesterone. You need to have a talent to juggle 3 balls. And so that's my advice to you. But if you have questions, let us know. But please don't go uninformed and suffer because you've heard fallacies that have now been proven to be fallacies, such as giving estradiol or taking hormones is going to increase your risk of breast cancer or heart disease or stroke or some other nonsense that is not supported by the medical literature. Thank you for your time, and we'll see you for episode number 46, where we will talk about the difference between micronized progesterone and progestates. Thank you.